This is your online spinal cord injury lecture. During this time, we're going to look at different spinal cord injuries and how they affect multiple systems throughout the body, and how you, as the nurse, will care for this patient population. Looking at the statistics of spinal cord injuries, two big takeaways from this slide, I would say, are the percentage of males that suffer spinal cord injuries and also the annual cost. Males tend to be at a greater risk of spinal cord injuries because they have more risky tendencies, risky behaviors. They're willing to try something that's maybe a little more dangerous. They also tend to have occupations that pose a higher risk. Now, the mean age of spinal cord injuries is increasing to be about 40 years old, and that's because of the elderly population and the spinal cord injuries that occur with them falling. We see in about 1/3 of motor vehicle accidents that when people are ejected from the car due to not wearing a seatbelt, that's about 1/3 of the spinal cord injuries from those motor vehicle accidents. More people are surviving now than before, really because a million years ago, well, not really that long, but a long time ago, ambulance or rescue squads that would go to accidents or reports of needing emergency services, they were volunteers. Now, that's not to say that they didn't have any training at all, but they're not really trained in comparison to our paramedics and our EMTs today. Not to mention that when you have a volunteer group like that, most of them are not in a building waiting for a call to come in, just like a lot of volunteer fire departments. They all come from their private homes. And so the time of response was greater to get to an accident than it is now. The higher the spinal cord injury is going to determine the patient's abilities, but really thinking about their drive to breathe, the higher the spinal cord injury, the less likely they are to have that drive to breathe. And we're going to talk about that more in depth here in a few slides. As far as the cost, a lot of these patients are going to need financial assistance. The cost to care for someone with a spinal cord injury in the first year is somewhere around $415,000, $418,000. Very, very expensive. If the patient should survive that first year, you're looking at probably somewhere around $75,000 a year to care for them after that point. Again, if they survive that first year. So looking into what exactly is a spinal cord injury, you see that on the slide I've provided for you. It's sufficient force to fracture or dislocate the vertebrae and damage the spinal cord, resulting in loss of sensory or motor function. A vertebral injury may occur without actually damaging the spinal cord. We're going to look into this a little more in depth. A few different types of injury I have listed here for you. With a compression fracture, the spinal cord gets squished, and oftentimes we hear about somebody diving into shallow water and breaking their neck, and then they're paralyzed and on a ventilator or something of that sort. So this is an example of a compression fracture. It just gets squished. They dive into that water. It's not deep enough. They hit their head. Not a good outcome. With a burst fracture, that's typically seen in the elderly population when osteoporosis in the vertebrae damages the cord. And with a vertebral dislocation, we'll see that with too much flexion or extension of the head. For example, in a fall, a fall can lead to the ligaments being torn around the cord. You might hear people say subluxation as well for the cause the vertebral dislocation. Now, with a fracture, it may or may not result in loss of function immediately, but it could a little bit later down the road if we don't do a good job in stabilizing that neck and that head. And we're going to talk about stabilization after a bit here too. We're going to begin talking about a couple different types of cord lesions. And I'll just say that in general nursing practice, we think about a lesion being a sore or some sort of little wound. But when we're talking about spinal cord injuries and lesions, we're actually talking about a transection or a cut to the cord caused by some sort of trauma. So a total transection is a complete severing of the cord. It is the worst kind of lesion. It is irreversible. You see loss of movement and sensation below the level of the injury. It is the worst, total transection. With incomplete lesion, it's a partial. Now, it's going to vary, but usually the patient will not lose both the sensory and the motor function. An example of this might be that somebody's stabbed by a knife, and depending upon where that knife blade hit, if it's to the sensory, if the injury is to the sensory neuron, they're not going to sense, they're not going to feel, they're not going to have that sensation, but they will be able to move. And just the opposite, if the injury is to the motor neuron, they're not going to be able to move. They might be paralyzed there, but they're going to be able to sense touch if someone touches them. So sensory neurons run down one part of the cord, motor run down a different part of the cord. You should remember this from anatomy physiology. But depending on what part is injured is going to determine the patient's outcome and their sensations or movement. More on incomplete spinal cord lesions here. Several different types listed on this slide. When you have an anterior lesion, light touch, positioning, and vibration sensations will remain intact for the patient, but you'll see that they lose pain, temperature, and motor function. Now, if someone has a central injury, they're more than likely going to have more motor loss in the upper extremities than in the lower. There's going to be variations in whether the bowel or the bladder, if they still have that sensation or not. For posterior, it is not real common, but if somebody does experience this, there might be a variation or a confusion as to where do I put things. Like if I'm going to step off of a curb from the sidewalk, where do I place my foot? Or if I'm walking across the street and I'm going to step back up onto the curb of the sidewalk, where do I place my foot? It's that hyperextension injury to the posterior spine, loss of proprioception you see there, no loss of pain or sensation, temperature, or motor. So they just kind of have to think about movement and where to place things a little bit more. But again, it's not real common. Now, Brown-Séquard syndrome, that might be due to like a gunshot wound, a stabbing, a fracture, ipsilateral paralysis with loss of touch, pressure, or vibration. The big thing with any spinal cord injury or lesion is that you need to stabilize the spine. You need to stabilize the neck, the head, the whole spinal cord. You need to just keep it very still to prevent any kind of further injury. Moving into assessment of a patient with a spinal cord injury, some things listed here for you on this slide. If the injury is C1 through C4, they lose that drive to breathe. They are going to be lifelong ventilator patients. They don't have the ability to breathe on their own. There's a little saying that says C5, my diaphragm is alive. So they will have the ability to breathe on their own. However, initially, when the injury first happens, they might be on a ventilator because of the edema that's happening with the injury. You think about any kind of injury you have, we get inflammation first, right? And then it starts to go away. So even though we say C5, my diaphragm's alive, if that's where their injury is, don't be surprised if your patient's not ventilated, or if they are, if they are ventilated initially. Just because when you get that inflammation, it's going to spread. It's not going to say, hey, I'm just going to hang out at C5. I'm not going to move anywhere. So the edema actually will move, and it can move upward. And what do we know? We just said C1 through C4, they have no drive to breathe. So as that edema from the injury at C5 moves upward, your patient's going to need ventilation. So don't be surprised about that. These patients, they're going to be quadriplegic, or you hear sometimes called tetraplegic. Really, it's the same thing at C5. Or even above C5, they're not going to have that ability to move. C7, your patients are going to have some ability to move their shoulders. So think about shrugging your shoulders up and down, but they're not going to have any use of like their arms or their hands. So fine motor skills like buttoning a button on their shirt, or zipping a zipper, or holding a pen, that's not going to happen. But they can have some shoulder shrugging, some shoulder movement, which is maybe going to make them a candidate for some sort of a device, as far as an apparatus that could be strapped onto them, that they could have like a long stick, and it could do some typing for them, or that sort of thing, with their shoulder movement. But they're not going to have any use of their hands. When we look at T1 through T11, these patients are going to be a paraplegic, and they're going to have loss of bowel and bladder most times. However, if it's an incomplete lesion, they might have some bowel and bladder function and control. So it really could go either way here. Just kind of depends on the lesion. Is it complete, incomplete? What's happening with it? They are not going to have motor function in their legs, but again, they're paraplegic, so their arms are going to work for them. So I can't stress enough, knowing the level of the injury is so important for you as the nurse, to know how to best care for your patient and what resources that they are going to need, and that you're going to have to educate them on, and get them community resources, get them support, and not only educating them, but their family. So your assessment and determining, you're not responsible for diagnosing, of course, but assessing the level of injury, and the team determining where that level of injury is going to let us know a lot about their care moving forward and what we need to do. Spinal shock. So when people hear the word shock, they think about a lot of other shock states, but I'm going to share with you information. But first of all, I want you to understand that spinal shock is not a shock state as you're thinking of it in other systems like anaphylactic shock, cardiogenic shock, etc. We'll talk about that more in a minute. But spinal shock, as you see, is a complete loss of motor, sensory, reflexes, and autonomic function below the level of injury because of the spinal cord being severed. Now, this lasts usually around 6 weeks or so, but can take as long as a year to resolve. In the one way that we are able to identify that this is resolving is that the anal tone, or the anal reflex, is present. So you're having a gloved finger with a little bit of KY jelly on there, and you're checking that anal tone daily for reflex. If the reflex is present, the anus will tighten around your finger. So people get excited to hear about that happening, because that means that this shock, this spinal shock, is starting to resolve. Now, patients that are undergoing the spinal shock, spinal injuries, they might become easily impacted. We've already touched on some bowel and bladder inability to control or to sense. We've talked about that a little bit already. We'll talk about it a little bit more here after a while. But you're checking them with your finger for fecal impaction. They're not able to evacuate their bowels. So you're checking already in their rectum regularly to make sure that they are not impacted. So as you're doing that, you're getting a sense of whether that anus is tightening around your finger, and that is indicative again of that reflex and that anal tone returning, and maybe giving us an idea if spinal shock is starting to fade away. So diving into the shock a little bit more here, neurogenic shock. Um, Again, this is different than any other of the shock states you might be thinking of, such as cardiogenic, septic, hypovolemic, anaphylactic shock. That's not the same. In those situations with shock, the patient's usually pale, they're cold, they're clammy, their body vasoconstricts to send blood to circulate, and increases the blood pressure. With neurogenic shock, the spinal cord has been cut, so the brain can't tell the blood vessels to vasoconstrict. So the opposite of that is vasodilation, right? So vasodilation in the arms and the legs, they pool with the blood. Our body ends up having a decreased preload of blood going to the heart. We have decreased cardiac output because of that. The patient is hypotensive. Again, the volume is not there. And so they're going to be warm and red. They're going to be bradycardic and really just in an underperfused state. So it's definitely different than the other shocks you are thinking of. Now, sympathetic stimulation doesn't work here, where normally there would be compensation of tachycardia. Again, in this state, they're experiencing bradycardia. So we need to try and fix this with fluids and meds and things of that sort. We got to help this patient out. So they might try some medications such as a vasopressor or dopamine. They're going to increase the circulating volume by giving the patient IV fluids, and even possibly putting them in Trendelenburg to use gravity to move that blood to the central system. We don't want to put them in a modified Trendelenburg because this creates more spinal cord injury potentially with lifting and moving of the legs. So how are you as the nurse going to help manage a patient with spinal cord injury? All trauma patients have a spinal cord injury until proven otherwise. Until proven otherwise. You need to get a spinal series, so there's going to be a whole slew of x-rays that come along with this patient arriving to your emergency department, your trauma bay. And you see different things here on your slide about how are we going to stabilize them. So stabilizing them with a collar, such as an Aspen collar or C collar, some of you have probably heard that or even seen that. Stabilize their head and neck manually. And using a spinal board, you should always be using a spinal board. And you need a minimum of 3 people to really stabilize and safely move this person. So one person will take the head, and that person's in charge of counting if they're going to log roll or move this patient. Another person will control the shoulders and another one at the hips. And it's beneficial if you can have a 4th person that could actually move the lower legs and the feet, but a minimum of 3 people. And the person at the head will say something like, okay, on my count of 3, we're going to roll this patient to the left or to the right or what have you. Looking here, cervical tongs, halo traction, thoracic and lumbar stabilization, all these different things, all useful resources and tools to help stabilize this patient. But the one I'm going to touch on here a little bit more is that halo traction. So that's that's where they take the, it looks like a halo, and they take screws and they screw them into the skull. And then it's got bars that come down and attach to like a shoulder pad type vest the patient wears. So when you're moving this patient, you never want to pull on those bars or move them by, touching those bars. You want to support them by their shoulders. It's also really important to check the edges of that vest for roughness. Make sure that it's not got any jagged edges on it. And that you can always fit at least 2 fingers underneath that vest. Otherwise, it's considered too tight. We know if something's too tight, too constrictive, it can break down our skin, gets reddened, and we end up with a wound. So you want to check on that. You're going to clean and check underneath that vest at least daily for breakdown, and wash and allow to dry before putting that jacket or that vest back on. Now it's covered in, they call it a jacket, but it's kind of like a lamb's wool kind of skin they put over top of it. You also don't want to put any powder or anything underneath that, but definitely need to check it every day for breakdown. Depending on the doctor that's caring for this patient with this spinal cord injury, he or she may choose to try high dose steroid therapy. You see here on the slide that it is highly controversial. There's also a few contraindications of why it shouldn't be used, but it can be beneficial in an injury less than 8 hours old. Now, when I say high dose, I mean really high dose. The hope of doing this is that it will lessen the deficit after the edema goes away of what their long-term outcomes might be. The edema essentially is causing ischemia to the spinal cord, and it's affecting the optimal functioning for this patient down the road. So if we can lessen that, lessen the deficits of that edema once it goes away, your patient might be better off. So they'll use methylprednisone, and they're hoping to, again, recover some of the neurological function and decreasing and preventing additional edema from coming on board. So you don't need to memorize the formula for this, but you should certainly be able to complete the math. But for example, they might do the prednisone, a bolus of 30 milligrams per kilogram, and administer that over 15 minutes. And they'll wait about 45 minutes, and then they'll start a drip for this patient at 5.4 milligrams per kilogram per hour for the remaining 23 hours in that first 24-hour period that they're with you. So for that bolus, you would take your 30 milligrams, you'd multiply it by the patient's kilograms. Let's say your patient's 80 kilograms. So 30 times 80 is 2,400 milligrams in the first 15 minutes. That's a lot. Wait our 45 minutes, and then we're going to start a drip for the remaining 23 hours at 5.4 milligrams per kilogram per hour. So I would take 5.4 times my patient's 80 kilograms. That's 432 milligrams of steroid per hour, which is over the next 23 hours, 9,936. If you add that to what they got in that first 15-minute bolus, they end up getting 12,336 milligrams of steroid in 24-hour period. So it is extremely high dosages. As we've already touched on, the spinal cord injury does not just affect the patient's ability to move. And so we've touched on some of the systems, but now we're going to take a little bit deeper look into these 4 in particular. First, looking at our respiratory system here, we talked early on in this presentation about depending on the level would determine if my patient needed a ventilator or whether they had their own drive to breathe. So with respiratory, dysfunction of that system is going to be related to that level of injury. They may have a compromised diaphragm. If they do, that's going to be a major factor in their respiratory, in their drive to breathe. Above C5, the diaphragm is involved. Remember we said C5, my diaphragm is alive. So below that, our ability to breathe without a ventilator is increased. C4 or above, they're going to be on a ventilator. Now, you got to think about other things just besides, okay, maybe I'm not on a ventilator, but you still need to think about, with restrictive movement, how's my patient going to cough or clear their secretions or spit, because they're still most likely going to have some inability to move to some degree. Um, Looking in particular at labs, thinking about abnormal blood gas exchanges. And you're going to need to know what is a normal versus an abnormal blood gas when you're looking at your labs. If you look at C5 through T6, the diaphragm is spared, but again, those intercostal muscles are going to be involved. And so that's in particular like the areas I'm thinking about with my secretions. Can my patient cough? Can they spit them out? How are they going to keep those secretions moved? Are they going to be able to move themselves in the bed at all? You know, we sometimes see our patients lay in the bed after, let's just say they don't even have a spinal cord injury. You see a patient that's recovering from surgery or for a stroke or something like that, and they spend too much time laying in the bed. What happens is all those secretions pool in their lungs, and then they develop pneumonia. So with a spinal cord injury patient, you have to be thinking about those sorts of things too. Even though the C5 through T6, that diaphragm is spared, they have that ability, that drive to breathe on their own. The muscles may not be functioning as normal. And so we have to be concerned about the secretions. How are we going to move them? How are we going to get them out? How is it going to affect our blood gas exchanges? Okay. Cardiovascular, we touched on a little bit of this already. Vasodilation below the level of the injury causes lowered blood pressure. We don't have our blood moving, so this patient's going to be susceptible to having a DVT due to the immobility and the hypotension, the bradycardia. So DVT is something we really need to watch out for. With the bradycardia, we know the body is trying to compensate, but it's not able to. You might see a little bit of compensation, but they have very poor vascular tone. This patient's going to be very vagal, stimulation sensitive. So those things that would cause that would be like coughing, suctioning them, bearing down. They're going to be very vagal, stimulation sensitive, and we know that affects our heart rate. And then orthostatic hypotension. You need to be sure that when you're raising the head of the bed that you're doing it slowly and in increments. Looking at our gastrointestinal and genitourinary systems, a lot going on here. With the gastrointestinal system, you're going to see gastric dilatation and potentially paralytic ileus. You're going to see that nausea and vomiting coming along with that. It is going to be so important as the nurse that you are assessing for bowel sounds, assessing for hypoactive bowel sounds. If we have hypoactive bowel sounds, that's not really a desired outcome or a desired assessment, but that's what you're really listening for. These patients are most likely going to need Fleet's enemas, Ducalox, Colace, diets high in fiber, calorie, bulk, high in protein, high in carbs. I mean, they really have to have their diet crafted carefully. It's beneficial to put them on a bowel program, sitting them on a commode. Let's say it's either the first thing in the morning or every time a meal is completed, but getting them into a bowel regimen, a bowel program. And then also you need to be thinking about ulcers, looking for port wine or black stools. Typically, you're guaiacking all the stools in emesis daily. Again, checking for bleeding, for blood in those specimens, indicating that there is potentially an ulcer. Checking your hematocrit on your labs. And you need to get these patients put on an H2 blocker. So this has got a lot going on here in the gastrointestinal system. Same thing with the genitourinary system. Assess the bladder. How many of you are really doing a good job with that? Are you checking to see how their abdomen feels and not just thinking about their bowel movement, but also thinking about when did they last urinate and how much urine was there? If their catheter is indwelling, how much is in the bag? What's going on? You really need to assess that bladder. So Do they have a UTI because they've got retention? Do they have a ruptured bladder or autonomic dysreflexia? You really need to give a lot of attention to this GI and GU system. If you have to put a catheter in, you need to make sure your sterile technique is at the very best. You get that Foley in as soon as possible, but you also want to get it out as soon as possible to decrease the chances of a urinary tract infection from an indwelling catheter. Don't let your guard down. Our patients with spinal cord injury have motor and or sensory deficits, and because of that, they're not going to be able to move or feel that something is hurting or pinched. So it's very important that you do a thorough inspection assessment of the integumentary system, looking for ulcers and skin breakdown. Make sure that you're assessing that skin, all the bony prominences, pressure points. You think about their hips and their elbows and the backs of their heels, all those things. They're not maybe going to have the sensation that something hurts there, that something is breaking down there, and they may not have the ability to move that body part depending on their injury, their spinal cord injury. So make sure that you are checking them over thoroughly. Look for any kind of redness and turn your patients, change their positioning, use supportive devices. Okay, I touched on this a few minutes ago when I was talking about the GI and GU system, but autonomic dysreflexia or hyperreflexia is a generalized body reflexive response to local stimuli. Okay, it's basically anything the body does not like. Exaggerates the sympathetic reflex response to local stimulation. So the body might receive stimulation from that distended bladder or fecal impaction. I talked about both of those already. A decubitus, a skin irritation, pain, heat, cold, menstruation, constriction of clothing, or pain. That is really, it's many, many things. There's many more things than what I have listed here. So what I might see as the nurse assessing a patient that's experienced autonomic dysreflexia is a hypertensive crisis. This is a life-threatening medical emergency. Hypertensive crisis, bradycardia, MI, a stroke, headache, congestion, piloerection below the level of the injury, which is goosebumps, and sweating above the level of the injury. And I'm not just talking about a little sweat. I'm talking about they are going to be drenched. You're going to be changing their clothes. You're going to be changing the bed sheets. They are going to be soaked. This is very seriously. You need to quickly move to get the stimuli removed from them, whatever is causing this. It is a life-threatening medical emergency. To treat this situation, the first thing you need to do is recognize it. You need to identify that something is wrong. Notify the doctor, remove the stimuli, sit that patient up, okay? Hypertension is the biggest problem here. You need to sit them up so we can decrease the preload and decrease that blood pressure. Catheterize the patient. If the Foley is draining, then the stimuli is not the bladder. We talked about this being some kind of stimuli that the body doesn't like. Well, if they've got a catheter in and it's draining just fine, then that's not the stimulus that's causing this problem. Check them for fecal impaction. Maybe they haven't evacuated their bowel. That might be the stimuli that's causing this problem. Remove shoes and socks, all their clothes. Remove the covers. We talked about it could be restrictive clothing. Remove anything that could be this potential stimuli causing the problem. You need to administer antihypertensives. If removing all this other stimuli doesn't fix the problem, somehow you've got to decrease this blood pressure. That's the biggest problem here. Okay. Moving on to spasticity here, the state of excessive muscular tonus, which increases gradually over the first 2 years and then begins to decrease. Now, this is not a return of function, but only spasticity. Patients sometimes get a false hope that function is returning, but it is not. Um, the tonus is the deep tendon reflexes, and we're going to manage by keeping aggravating factors to a minimum, okay? Using physical therapy and antispasmodics. Baclofen, dantrolene, they pump those into the spinal column. The PT is going to keep those tendons and muscles more supple. And possible cordectomy, which is where they surgically cut the tendons to decrease the spasm. But it's sad, but you'll see patients get excited when they think that their function is coming back when really it's just the spasticity. Sexual dysfunction is a reality for many spinal cord injury patients. You'll see here on this slide the differentiation between females and males. With females, they can become pregnant, an early C-section to prevent the dysreflexia. They're going to schedule that early on, and they may lack that sensation during intercourse. With males, lots more information here. Most cannot ejaculate, but if he is able to ejaculate forward, there is going to be poor sperm quality, but most men with the spinal cord injury will ejaculate backward. And because of that poor sperm quality, if there is a forward ejaculation, they cannot father children. Emotional support is incredibly important for patients with spinal cord injury, and this really affects the whole family. In most families, the spouse will become the primary caregiver, and it's incredibly hard on them physically and emotionally as well. Patients will go through a grief process. It's important that we listen to them. We don't want to tell them that we understand because we have not been there, but it's important to validate their feelings. Allow them to express those feelings of denial and anger. They're going to go through moments of weeping and crying and moments of rage. Recognize all the things that the patient is able to do well, and offer them spiritual support. Now, immediately in the hospital, there's usually chaplains of multiple faiths, and it's important to ask them if they would like for someone to come and speak with them. And if they move on to like a rehab center or something of that sort, there's usually a rotation of people that come in and are happy to meet with patients and families. And for young people especially, don't avoid talking about sexual function and counseling, sexual counseling. It's a big part of their life, and you know, besides maybe not having the ability to walk or to care for themselves, you know, not being able to engage intimately with their partner really can affect them. Patients with spinal cord injuries are definitely going to need rehabilitation no matter what level they're injured at. And no matter if it's a partial lesion or a complete transection. It should be started as soon as possible. And we want to encourage the patient to have as much independence as they possibly can, dependent upon their level of injury, to care for themselves. Again, focusing on the things they're able to do well, focusing on the positive. There are some devices that are incorporated into rehabilitation, braces and assistive devices. You might remember when I was talking earlier about the patients being able to shrug their shoulder and have an apparatus attached to it that maybe has a stick or a stem on it that can help them, you know, use that wand or that stick to type at the typewriter. There are pancake call lights. There's voice-activated computers for texting and for writing as well. It's going to be important during the rehabilitation process and potentially lifelong that they have continued counseling, mental health counseling, and not only for themselves, but again for their family and for their care provider. Oftentimes it's being the spouse or significant other. Make sure that they are engaged and aware of community resources and support groups. There are some support groups that get together that are not for the patient, that are for that care provider. as a caregiver support group, or for the family. And then find what resources are available as far as home care, like agencies that can potentially come out, respite care for the caregiver to give them if they need a couple of days away, a weekend, a month, or something like that. There are resources. So work with your social workers, and this will continue on not only in the immediate hospital phase, but into rehabilitation, and get them connected so that we can make the rest of their life as good as possible with, giving them emotional and physical support through resources and groups.